In this video, we'll discuss about leprosy antileprotic drugs. First, we want to look at what is leprosy. Leprosy, also known as Hansen disease. It is also known as Hansen's disease. It is a chronic infection by the acid-fast bacterium, Mycobacterium leprae. So acid fast bacteria, Mycobacterium leprae, that leads to damage the nerves, respiratory tract, skin, and the eyes. There is lack of ability to feel pain in the extremities due to nerve damage. So it leads to damage to nerves, respiratory tract, skin, eyes. There is lack of ability to feel pain in the extremities due to nerve damage, and this can lead to loss of parts of extremities from repeated injuries or infection due to unnoticed wound. The product lesion can manifest as a variety of different appearance, but typically macules, papules, and nodules. So this one can lead to lots of part of extremities from repeated injury or infection due to unnoticed wound. It produce lesion as a variety of different appearance, but typically as macules, papules, and nodules. Now, World Health Organization classify leprosy as paucibacillary and multibacillary, where paucibacillary simply means lower quantity or number of bacilli found in the lymphatic region. So, where this paucibacillary simply means lower quantity or number of bacilli found in lymphatic region, while multibacillary means more bacteria, more bacilli found in that lymphatic region. Now, leprosy is a disease that can manifest in varying degree and not as a defined clinical manifestation. It's more like a spectrum. So that's why we have another classification name is called Redley Japlin classification. Classification name is called Redley Japlin classification, showing the clinical spectrum of leprosy. The spectrum started from tuberculosis. This one is the lepromatous leprosy. In between this one middle borderline. So middle borderline and this one is lepromatous leprosy. In between borderline leprosy. In between this tuberculosis and this middle borderline, in between we have borderline tuberculosis. This one is the borderline tuberculosis. This one is borderline lepromatous. Totally 5 different type of leprosy. We are starting with the less severe to more severe form. This one is the less severe. This one is the more severe form. What happened here? Mycobacterium leprae is an intracellular pathogen. So at tuberculosis pole we have good cell mediated immunity. Here we have good cell mediated immunity. That means that a killer T cell, CD8 T cell, will kill the cell that are infected by Mycobacterium leprae. That's why this case is less severe, not that infectious, but we go from the tuberculosis pole to that lepromatous pole. the cell-mediated immunity decreases and taper down. That's why lepromatous pole is more severe and more infectious. Next, the skin lesion and number of bacilli in the lesion also increase from the tuberculoid pole to the lepromatous pole because of the same reason. Because there is good cell mediated immunity in tuberculoid pole, here bad cell mediated immunity at lepromatous pole. Now we want to discuss about lepra reaction. There are two type of lepra reaction, type 1 and type 2. Lepra reaction are immunologically mediated episode of acute or subacute inflammation. This type 1 is mediated by the type 1 helper T cell, and it is basically type 4 delayed cell mediated hypersensitivity reaction, while type 2 lepra reaction is mediated by type 2 helper cells, and basically it is a type 3 hypersensitivity reaction that involve immune complex formation and deposition. The type 1 reaction can occur in both type of leprosy. There is that falsi and multibacillary, while the type 2 is more specific for multibacillary leprosy because the leprotic end of that spectrum had more humoral immunity. So more of the antibodies, more of the chances of immune complex formation and deposition, and thus worsen the type 1 can manifest as red, warm, swollen lesion that are tender and painful. Also new lesions can also appear. Well, type 2 will be same, red, painful, tender, cutaneous and subcutaneous nodules, as both of these reaction hypersensitivity reaction. That's why they need immediate management with rest, because these are usually elicited by stress or any sort of physical activity. They need to managed with rest and safe systemic corticosteroid etc. To manage by stress or any sort of physical or stressful activity, and they need to manage with rest and safe systemic corticosteroid etc. Finally, coming to the drugs used in leprosy, there are tapzone, clofazamine, then rifampin, ethionamide and minocycline. The only tetracycline that can be used in minocycline. Coming to tapzone, this one actually a diamino diphenyl sulfone. It is the oldest and cheapest and most widely used drugs in leprosy. The mechanism of action similar to sulfonamide because it's structurally and chemically related to sulfonamide. That is, it will inhibit dihydropyrote synthetase. Thus inhibit folic acid synthesis that is required for growth and multiplication. It is leprostatic drugs. This one is the leprostatic drugs. The pharmacokinetics properties include its oral administration, go to gut, a gut absorption, high plasma protein binding, and it is concentrated in infected tissue, that is skin, muscle, liver, kidney, etc. Its metabolism in the liver by acceleration, and the metabolized form is excreted. Metabolized form excreted in the urine, while the unmetabolized form is excreted in bile, while is then recycled. The side effect include sulfone syndrome. Now this is actually a hypersensitivity reaction characterized by fever, dermatitis, pleuritis, lymphadenopathy, methemoglobinemia, and hepatitis. Second, it is also associated with hemolytic anemia in glucose 6 phosphate dehydrogenase deficient patient, just like inosite azide in anti-tuberculosis drugs, also methemoglobinemia and peripheral neuropathy. Coming to clofazimine, its mechanism of action, it is binding to the microbacterial DNA to inhibit its step template function. That's why the DNA cannot act as a template for new DNA strand formation, and it is a leprostatic drugs, and it also has anti-inflammatory property, and that it can be used in the type 2 leprotic reaction. It can also work against that organism that are resistant to tap zone, and it has a very long half life, actually 70 days. That is very good because leprosy treatment can go up to 2 years, 2 to 3 years, and it also accumulate in tissue. The side effect include, first is contraindication, that is should not be given in pregnancy. It causes reddish brown discoloration, exposed part of that skin, and also pigmentation of conjunctiva and cornea, discoloration of hair, tears, sweat, and urine. In GI, gastrointestinal side effect will include nausea, vomiting, diarrhea, abdominal pain. Next, rifampin. It is a sidal drug. It will inhibit RNA synthesis. Ethinomide. Ethinomide. It is used when clofazimine cannot be used, but it is hepatotoxic. Lastly, tetracycline, that can be used in leprosy and has anti-leprotic activity, is minocycline, while fluoroquinolones such as of oxacillin and oxyfloxacin used can be used. There is sidal and microlides can also be used, such as clarithromycin. We use multi drugs therapy. The reason are the same as the reason we are using multi drugs therapy for treatment of tuberculosis, to make the patient non contagious as soon as possible, to prevent development of resistance, to prevent relapse, to shorten the duration of overall treatment. Thanks for watching.